Yeah, we'll just give it a couple of minutes for Stella to hopefully join her call from her last call. But nice to see everyone joining this afternoon. And yes, as Lacey has mentioned, it would be great to know who we've got with us today. So if you do want to introduce yourself in the chat in the meantime, that'll be lovely. Great to see all the introductions. Got a great range of people coming from all over the country. Lovely. For those joining while we're waiting, was anyone at the Lunch and Learn event earlier? And did anyone have any thoughts or takeaways from the presentations and the discussions then? I think Stella's just logging in now. We'll just give you a minute.
Yes, apologies for causing a heart attack, Claudia.
That's all right, no problem at all. I'm not sure if you can see the chat since joining, but we're just getting a lot of introductions from our audience today. A great range of people attending this event. Lovely. How are you doing, Stella? Are you all good at your end?
Yes, no, fine. Just jumping in from one thing to another. So my apologies in the delay.
No problem at all. Great. Well, I think we've got 60 and counting, so I think probably we can get started, and as and when people kind of join in, they can catch up and join as and when. And thank you everyone that has introduced themselves in the chat. We'll be keeping an eye on that throughout this session. Someone saying there is an echo on the speaker. Is anyone else having issues with hearing us, or is it just Joanne, I think? Dan saying no, audio's okay. All right, perfect. We'll carry on as planned then. And Joanne, hopefully it might be something that you can resolve at your end. Perfect. Well, it's great to be here for this final session of HQIP's Clinical Audit Awareness Week in collaboration with NQI Can. And I hope we've got a really interesting session for everyone dialing in this afternoon. Just a bit of housekeeping. I'm sure you'll have seen when you joined the session that it is being recorded. If anyone has any issues with that, please just drop a message in the chat and one of our team will pick that up. So I guess in terms of just some brief introductions, my name's Claudia. It's lovely to meet you all. I am a clinical fellow at HQIP. I have been here almost a year now. And my background is I'm a doctor, I'm a GP registrar. I'm currently based in Cambridge, but I have previously worked in Liverpool as well. And yeah, so I'm kind of at HQIP for a year. As part of my role, I get the lucky opportunity to work closely with Stella at NHS England. So Stella, I'll let you do your own proper introduction in a minute, but just as a bit of background, Stella is a consultant in vascular and general surgery at Croydon University Hospital. And since last year, she's also the National Medical Director for Secondary Care and Quality. And I'm going to be spending a little bit of time chatting to Stella about some of her thoughts and reflections on her role as a kind of clinician and in her role at NHS England. And then hopefully we'll have some opportunity towards the end of the session to get questions from you guys and hear your thoughts as well. So without further ado then, Stella, I know you're kind of relatively new in your role as National Medical Director for Secondary Care and Quality, but I wondered if you could maybe just give us some background or a little bit of a summary onto your journey kind of so far, what you've done in the past and how you've ended up in this role now.
Thank you very much. And just to say to everyone, I'm also lucky that I work with Claudia the other way around. Claudia, you are phenomenal in what you do and produce. So it's been great to be working with you this year.
Thank you.
Okay, so my day job, as Claudia says, I'm a vascular and general surgeon based down at Croydon. Started off in 2004. So have been clinical for a long time, but interested in management and leadership. So was clinical director for essentially a third of Croydon Hospital, and started off as the national clinical director for elective care back as COVID really started, as we started coming into elective recovery. So that was 2021. So I've completed 3 years and have now been reappointed for a further 3 years. But the National Medical Director role was advertised and have been fantastically fortunate to be appointed to that in November of last year. And I think for me, it was really exciting because I very much feel that performance and quality, and therefore audit and quality improvement, actually we should be using those words in the same breath. And by becoming the National Medical Director for Secondary Care and Quality and NCD, we can really start pulling together the quality and performance elements of what we already do really well in the NHS, but perhaps think about that in a slightly different way. So for me, where I've come in the role is in Croydon, we did some transformational change that separated elective and emergency care. We started elective recovery, but of course that then brings in all the other areas. And I just want to say thank you to everyone on this call for their hard work in ensuring that patients do get timely care. We've got a way to go, but we are so much better than we were as we were coming out of COVID. But as we go forward now, the excitement in the roles that I have is that transformation and innovation have got to be key, because all of us, including me, are tired, and the opportunity to do more and more and more on weekends and evenings and everything else is becoming more and more difficult. And then things like clinical audit become a passion and an add-on rather than what we should be doing every single day. So for me, Claudia, a lot of it has been real opportunities since COVID. And I think sometimes doors open for you and you have to walk through and then see how you go. So that's really been my journey, but I'm really enjoying the role I'm doing and looking forward to continuing doing this for a while.
Yeah, no, that's great to hear, Stella. No, that's yeah, really interesting. I think you and me actually started in our roles at kind of similar times, so it's been great kind of working together and getting kind of used to the environment and the new bits of each of our roles. I'm going to pick up on some of what you said a little bit later, but I'm gonna take you back now to kind of more of the clinical role that we both face as clinicians. We I'm working in primary care, you're working in secondary care. I think as clinicians, we're always involved with kind of quality improvement projects and audits as part of our training and as a consultant going forward as well. I was just wondering, kind of from a clinical perspective, do you have any kind of reflections on what role kind of audit plays in your job day to day when you're practicing kind of on the ground?
Yeah, no, absolutely. I think, as a clinician, it's part of our everyday practice. And there is so much data now that we rely on that drives the work that we do. So if I think back to some of the early audits that changed my practice, so the 7-day audit for weekend working and actually ensuring that patients are seen every single day, that there are senior decision makers, affected what we did. The traditional management of surgical patients over the weekend was that they were seen on a Saturday morning, then not seen again till Monday. That practice changed through the 7-day audit, and now patients are seen every single day, senior decision makers, and we expect senior decision makers, if you've got a laparotomy at night through NELA, a senior clinician should be present for that. So it is driving everyday workflows in terms of what we do. But we've also got other audits that are used. So again, in my practice as a clinical director, looking at the National Vascular Registry and EMBOCAP for the cancer outcomes, it drives change not just for us, but actually as a service. How do we perform against our peers, and what are our peers doing that will drive change, and therefore what do we do with our own service to make that change? But I think we're now developing much greater insight, Claudia, and it's, the triangulation of data is going to become more and more important. Our patients are going to demand it. And so if you look at the National Consultant Information Portal, NCIP, and the independent sector with Fin, the triangulation of data in terms of what we do in our everyday practice and actually our service, I think is going to come to the fore, and again, is going to be really important. And most of us, the majority of multi-professionals who work in the NHS, and actually most of our operational colleagues who work in the NHS, they're altruists. If you were an operational manager who's not an altruist, you wouldn't be working in the NHS, you would be working in a different sector. And I think we all get our positive energies from great colleague and patient feedback, and the audit process supports that for most of us. But I think the other thing that we're seeing on a regular basis, our trainees are doing great audits, but at the present they're still single professional audits. We're not really doing multi-professional, multidisciplinary audits and then converting them into QI projects that are embedded into the organizations. But, audit is, it was new. It's now part of our everyday practice. We now need to think how we strengthen it, get real-time data, and actually support real patient safety and improvement in very short time periods, rather than waiting for data that comes out, a year, 18 months after it's first collected.
Yeah, I'm sure many of your comments reflect with the audience we've got today, and I'm sure they might be picked up on further kind of later on in the session, but definitely agree, there's I think big changes that could happen in the future in terms of our data in particular. And I definitely agree with what you say about kind of having a multidisciplinary approach to audit. Definitely as a kind of trainee doctor, I think you are often expected to be doing audit and quality improvement as part of your training, but it's very much and kind of an individual thing, and you're not using the wider team around you maybe as effectively as we could. So that's a really good challenge, Stella, and something I think for us to kind of think about going forward. I'm wondering now about your role kind of at NHS England since you started, and what your role as National Medical Director for Quality kind of entails, and whether that's changed your perspective on clinical audit. And I just wondered, kind of contrasting to you and your day job as a clinician versus your job in NHS England, can you give us some insight into kind of the differences and your perspective on audit now?
Yes, I think I hadn't realised how small providers were in the very large wheel that's clinical audit. Just to put things into context, so quality runs all the way through the NHS and obviously at multi levels. Within the NHS, it's held by my boss, Steve Powis, who's our National Medical Director, by Ruth May, who's our Chief Nurse, and also by Emily and Emily Lawson and Sarah Jane Marsh, who are our Q and Deputy Q. Audits and registries sit with me, but they're also sat with Tim Briggs with the medical devices outcome registries and the outcome registry programme. And as you all know, the outcomes for patients with mesh and some of the breast implants, which have been in the news, have been really difficult to deal with. And the medical devices outcome registry is fundamental in making sure that our patients are safe. But I think that the main thing, Claudia, is I hadn't realised how many audits exist.
Me too. Me too.
You know, I was, I was clinical director for the division, which was radiology and pathology and pharmacy and so many more. But I just hadn't realised how many audits existed outside of that sphere. And I have to say, I'm incredibly humble to all our clinical audit teams who are providing the data. But also, Claudia, I think especially through EQG CAS, the number of new audits that are developing and are needed. You can add audits on for the purpose of adding on audits, but actually these are audits which are driven by really passionate teams and are there for a reason. So the number of audits that we have are becoming larger and larger, but our clinical audit teams are small. And what I heard loud and clear on a clinical audit webinar, which I think was about 4 months ago, was our clinical audit teams don't feel that they've really got a home. They don't really feel that they are at provider level supported by the medical directors. And I think there is some work to do at national level to ensure that our clinical audit teams are really valued. But it is interesting to see how the data flows through HQIP, which again was new to me, and how we now start to look at data collection, streamline that data collection. And for me, I think the biggest thing, Claudia, especially chairing EQG CAS, is how recommendations are made and how they're landing with the organisations that have to implement them. And the risk that we have is that we overload our clinical teams or our providers, and actually they just can't deliver against the recommendations that we're setting. So I think for me, it was a realization of the amount of work that's going on, but actually, how do we get it right for our clinical teams?
Yeah, and I think you've led nicely into an area I kind of wanted to pick up next, which is the EQG CAS meetings. I thought it might be useful just to provide a bit of context to those on the call about how things operate between HQIP and NHS England with regards to the NCPOP audit reports that HQIP publish. So for those of you that kind of aren't aware, EQG CAS is standing for the Executive Quality Group Clinical Audit Subgroup. And it is a group that meets probably about 5 or 6 times a year within NHS England. It's attended by the national clinical directors and relevant teams out of NHS England. And as Stella has mentioned, she chairs the meeting. I attend on behalf of HQIP, and I'm responsible for kind of pulling together whatever reports have been published since the last meeting that have recommendations targeted at national level. And it's a chance essentially for these reports to be discussed and recommendations to be discussed, and kind of decisions made at national level about how best to implement them and what action is happening in response to the recommendations. So I think you've kind of alluded to some of the bits regarding the EQG CAS meetings, but I wondered whether we could kind of focus more specifically on what you think the meetings and this group is doing well at the moment in terms of kind of driving clinical improvement forward.
I mean, I've only recently taken over the chairmanship of that, and I think I suppose there are three things that really struck me. One, Claudia, HQIP, and especially yourself, in terms of reviewing actions and the audits that are being produced. That data set is really helpful. We have wide memberships. So the membership includes the devolved nations plus many other communities of practice, which has been, again, very, very helpful. And the third was there was trust in the room, and so there's some really good discussions that take place. But there was a however, and the however was that we've got, as I've said, multiple audits being carried out, and the audits are wide-ranging. So a meeting might encompass, you know, for example, the NELA audit, the National Emergency Laparotomy Audit, but may also cover respiratory and maybe pediatrics. And it's difficult to get the right people in the room, but also to use that time well. It's very easy now, especially on Teams, to be on meetings all the time. And I think if we've got people in the room, especially when we've got senior people in the room, well, to be honest, if you have anyone in the room, that we use their time well. So we've had an opportunity just to consider how we manage those meetings. And we've had an opportunity to test theming the meetings, where there's audit and synergy between some of the audits. And we ran, Claudia, your help here was incredible. We ran a maternity themed EQG CAS, where we had the devolved nations, maternity services, women's healthcare, pediatrics, and so many others. But we also linked it through to the maternity action plan and the pediatric and women's health action plan, and considered the recommendations that were in place, who owned them, and how did we start to make implementation of some of those recommendations easier for our colleagues within hospitals. That worked really well. We had really good feedback. So we are now theming those EQG CAS meetings, where we get an opportunity to reflect on the recommendations that are made from the audit programs, and consider how they're being implemented and where people need a little bit of help to get things going. So, for example, Cancer NELA and the Trauma Registry might be a good confluence of audits. So for me, I think EQG CAS has been a really good meeting. NCOPOP audits are really well managed. And I think what we now need to do is to consider, how do we use people's time well in those meetings and make sure those meetings are now purposeful in terms of what we need to do next.
Yeah, completely agree. And I agree with what you've been saying in terms of how the meetings have evolved, you know, over the last couple of months. And the maternity theme meeting was a really good chance to trial kind of a slightly different format. And I think it will be really exciting to see how that kind of themed approach develops, and whether we can get kind of a broader, more kind of intense discussion on certain kind of themed areas of health and care as a result of kind of grouping things under different topics or themes. So yeah, something maybe to reflect on in a year's time and see where we're at, perhaps. Great, no, that's really helpful, Stella. I think going kind of outside of NHS England then, and EQG CAS back to kind of our local kind of clinical audit communities, which I think are making up the majority of people here today. I wondered, and you've kind of touched on some of these things already in the discussions, but maybe this is a chance to pull this out a little bit more. What your thoughts are kind of more broadly around what you feel some of the challenging aspects or some of the difficulties National Clinical Audit is facing, particularly at the kind of local community level. And, I think this will probably come out later in discussions as well, but it'll be good just to kind of have those thoughts laid out. I know we've mentioned some of them in terms of the big burden on actually getting hold of the data and the sheer number of audits that are in circulation at the moment, and the need for more as well. But I wondered whether there was anything else that you kind of felt was a challenge in this space at the moment.
I think I've covered a lot of it, and
Yeah.
Diane's also alluded to it in the chat.
Yes.
We've got small teams delivering huge volumes of work. And when we talk about clinical audit and effectiveness teams, sometimes you've got 2 or 3 people. Behind that, you've got multi-professional clinicians finding data, adding that data in. If you look at the hip fracture database, you have some of our trauma teams, our trauma theatre nurses adding this data in actually as part of their job, but it's not actually part of their job. And there's always the conversation of data quality. So, and I suppose the other conversation is that as our audits increase, and I suppose that's another conversation with EQG CAS, is as our audits increase, the NHS isn't a sole trader. We work with professional bodies and so many other groups, third sector, patient support groups. But as we increase our audits, we increase the stakeholders that need to be planned into the conversation. We've seen recently there's been clinical challenge, and there's been really poor clinical outcomes. And I think our patients and stakeholders are now really going to want to see us act on real-time data. And as I've said before, I just don't think that data that's in a year to 18 months old, or not being able to spot a pattern or a red flag earlier, is going to be credible as we go forward. So I think we now really need to develop a strategy. We've got the federated data platform. We've got the ability to pull data automatically, to reconsider some of the data volumes that we've got. So, we've got people who put audits together and pulled, I don't know, 150 data sets that come in, and actually perhaps we only use 100 of those to actually drive clinical care. So how do we do that? Automated data collection, the smart analysis, and almost like some of the educational databases where you can almost plug and play. You can ask to answer a question, but you've also got the really good audit processes is in play. And I think underneath that, Claudia, we just need to make sure we've got the right safeguards to make sure data is controlled and used appropriately, but it mustn't block doing what we want to do. So I think those are the challenges for us as we go forward.
Yeah, and I think you've also alluded, my natural follow-up question was, what do you think we should be doing about things from your perspective? And, do you have any thoughts about where the future direction is? But I think you've kind of alluded to that in your comments, and I think there's some useful comments being dropped into the chat as well, which is great. Thanks everyone for your thoughts and your input into this discussion. I think, before we kind of open things up to everyone else, thank you, Stella, for your insights and how honest you are about, where things are at the moment and where improvements might be, being made going forward. I'm wondering whether there is anything specifically that you wanted to kind of leave as a take-home point to kind of our clinical audit community listening into this call at the moment, or anything that you think is kind of important to reflect back before we kind of open into a wider discussion.
So I think for me, clinical audit is really important. It drives our everyday practice, and it keeps us safe, but it also keeps our patients safe. I'm really keen that it drives quality improvement, and I think in terms of HQIP, the link that you have to the QI resources and the toolkits to embed change, I think is really, really exciting. But I want to see this develop over the next few years, and it should be everyone's business rather than just those that are passionate. But what would be really, really helpful as we open up into the questions is what makes people's lives easier? What can I do? What mechanisms do I have that you need me to drive home that actually would make people's lives easier in delivering clinical audit? What would add clinical value? So clinical audit needs to be, I say, an everyday word, Claudia, but I want to know how we make people's lives easier when we're delivering it.
Yeah, no, thank you, Stella. Absolutely agree. And there's lots of things coming into the chat now. I just wonder whether this might be a good time to ask those attending on this call, does anyone have any kind of immediate response or thoughts on kind of Stella's question? Is there anything that we could be doing in our position, at HQIP or at NHS England, from Stella's perspective, she says, that can drive things forward? And equally, kind of in return, is there anything from those on the call at the moment that want to ask kind of Stella herself? And let's have a discussion, because it's a really unique opportunity, I guess, to have everyone in the room together with a chance to discuss these things. So yeah, please feel free to kind of write comments or questions into the chat, and between me and Stella, we will keep an eye on things as best as we can. And it gives us a bit of time to catch up on the messages too.
I was going to say there's an interesting message which is, starting audits is fine, but people get, it's really difficult to stop an audit, and it is interesting. We do need to consider when an audit has done what it needs to do as an audit, and how it becomes, business as usual and just embedded in the way that we work in the NHS. And I don't think that's always clear. So I think that's a really good comment. There's some really, really helpful comments coming in. It'd be lovely to hear people's voices, though. I'd love to hear some questions.
We've got Carl, I think, with a hand up. Carl, do you want to unmute?
Hi. Hi. Having sat on that group that Stella now chairs for 6 years, I suppose I've got a little bit more insight to this than some maybe. So again, that's why I'm brave enough to put my hand up to start the conversation. So I put the 2 main points in the chat, but just to build on those really. So all the way through Clinical Audit Awareness Week this week, I've heard language being used interchangeably about audit, QI, clinical audit, continuous improvement. I think we really need to define that so that we're all talking the same language and understanding where we're coming from. I've used clinical audit for many years in my trust as a quality improvement tool, but not a lot of people do. Some people just think audit is for assurance and to check how we're doing against standards, and then that leads on to the quality improvement. In Leicester now, we've sort of done a hybrid where we know the answers to the problems. The clinical audit cycle can be successful in terms of just doing it and reinforcing guidelines and good leadership to make people aware what they should be doing. But ultimately, if you don't know the root cause of the problem and you don't know how to fix it, then that's where the advanced QI methodologies comes in. So I think we do need clarity around, a lot of trusts use national clinical audit for quality improvement, some don't, and use it just for assurance or whatever. So that's my first point really, in terms of can we have some guidance from centre, especially now we've got the NHS impact guidance where some of these things are used interchangeably and not really defined that well, in my own opinion. So because I think quality improvement hasn't been defined within the NHS for quite some time really, and it probably needs to be now. And the second one is that I'm a big ambassador for good quality national audit. It's very good. What we don't do very well as part of the commissioning process is that we don't look at the impact that this has on local trusts. So we agree a good project, we know the need for why we're doing it, we collect the data, good robust measures, etc. But we don't look at the impact of how is that data going to be collected, whose responsibility is it for it, how is that going to be funded, how can we actually make this happen in local trusts, because we've got about 100 on the HQIP directory now in terms of national audits as an acute trust, and there's lots of others that aren't even on that list that we try and take part with, because we're a large acute teaching hospital. hospitals. So, and it is a nightmare in terms of trying to coordinate all this and data quality and make sure that we're driving improvement. So I think it just need to be a little bit of, is this adding value? Do we really need to commission this? You know, we've set the tools up now. You can run your own local projects potentially, but do we really need to have it from centre and costing the NHS a lot of money to run, etc. So, because we've just done a multi-site audit across all of the I think we've got about 90 centres involved. It didn't cost anyone any money. We got the data collected real time, and we're using it for improvement. You know. To drive improvement without having to go through the big commissioning process that is attached to the NCOBOT projects. So that's just a bit more detail to the 2 points I've made. And as I've said in the comments, I'm quite happy to discuss through that with any more detail with anybody who's interested.
Thank you, and Carl, you bring up really good points, and there will be a conversation about the strategy. There's a question in the chat about I think, Gary, when might MDOR and ORP be rolled out? They are doing a limited review at the moment of registries that wish to work with them, but we will be we've been commissioned to consider a strategy for audits and registries, and I think, Carl, that hybrid model that you describe is probably going to be the model for the future, but we will be asking for sorts. Will go out to consultation, and I think, you know, the conversations that you've had are really valuable, really valuable, because there's limited public purse and we need to use the money in the right way. There's also a conversation from Claire, that you've recently retired a national ambulance audit, which is wonderful to hear. But I suppose, you know, is there a conversation that as audits come on board, that we put a time frame on them to say you will be retired in, because actually at that point you should have generated the toolkits that actually start to develop. And Carl, I won't go into the because I use clinical audit QI, and I use that interchangeably myself, and I do it all the time, and please forgive me. But no, your points are really well made, so thank you for putting your hand up. I think we've got Emma as well.
I think Diane is.
Right, let me let you share.
Thank you.
Go on, Diane.
I just wanted to say thank you for kind of being on our side from the point of auditing the community. And just one of the things I wanted to ask was, is there any plans for more investment for the clinical audit teams? Because at the moment, you know, as you said yourself, QI has taken over all of the NHS. Nobody kind of aligns clinical audit anymore as the improvement. It's always quality improvement. And that seems to be where all the trusts have aligned all their resources to as well. So we've got minimal staff within our clinical audit team that take on all the work of the trust, all the national audits. But then you've got the QI teams that have come into the trusts. They're on much higher bands than the clinical audit teams, doing a lot less work. And it just seems a bit unfair that we're getting all the burden without any kind of resources behind that.
So I'm not going to promise you any extra money, because if I do, I'll get shot, especially where we are at the moment in terms of pre-election. But I haven't got an immediate answer to that for you. But what I have got is a fantastic lady that's come to work with me called Liz Lingard. I've sidetracked her into audits and registries at the minute, but she's my head of clinical effectiveness. And I think what she will do, Carl, firstly, what you've asked for, which is we need some clear definitions. 2, we need to understand and actually look at the resources we have and actually consider how we use them to the best. So the answer is I haven't got an answer for you right now, but I know it, and we need to plan what we do. And I think we need to give guidance to organisations in terms of, you know, NCOBOT is brilliant. It's brilliant at what it, you know, the audits they produce in terms of HQIP and the work that HQIP does and the recommendations that come out. But have we really got ourselves embedded at trust level, provider level? We haven't got data coming in from community. We haven't got data coming in from primary care or independent sector. So there's a way to go. So I'm hopefully in the job 3 years. Let's see what we can achieve together.
Thank you.
Thanks, Stella, and thanks, Diane. I think Vicky on my screen, you're the next hand. So.
Oh, lovely, thank you. I think that was really refreshing, Stella, and you got some lovely comments in the chat. The point I've put in the chat, I think, is the fact that when we are participating as provider organisations, and I know I've said this before and I've fed it back to HGroup as well from NQI Can, it's the expectation that we have to participate in everything on the quality account and only a proportion of NACPOP. And NACPOP's methodology is quite robust and it's monitored and reviewed. There's that whole commissioning process behind it, and the projects that then get accepted onto the quality account aren't NACPOP, don't have that rigor behind them, and we sometimes struggle to do absolutely everything that's on the quality accounts. I always say to people, if they approach me and say we can't do everything, please do your NACPOP ones first. But obviously I think it's all in the NHS standard contract now that we must do everything that's on that quality account, and that's where we struggle. And if we're having that discussion at a local level with our boards and our execs and non-execs, it's very much around, well, actually, if we can't do it all, the NACPOP are adding value and they're robust, but some of the other topics on the quality accounts where we're not seeing it, maybe those are the ones where we actually don't participate because we struggle to do absolutely everything. So I suppose it's, if those topics go on the quality accounts, we're being told they're important to do, but actually if they are really that important, should they have a bit more rigor behind them to support us so that we can effectively participate and then make those improvements on the ground for our patients. So yeah, that's another aspect we do struggle with.
Victoria, thank you. Actually, to be honest, I hadn't considered that. So let me take that away and look at that conversation with the team. We need to be making your lives easier, not harder. And I say, if we can, if there is any chance that we can automate that data collection, it would make people's, then you're talking about reinvesting time rather than reinvesting money, and that becomes an easier conversation. I am told that is, a 3 to 5 year conversation. I think that's where we're at. But no, thank you for the comments. It's a really helpful conversation.
Thanks, Vicky. Yeah, absolutely agree. I think we have another hand from Emma. Emma, are you able to unmute and?
Yeah. Hi. Can you hear me?
Yeah, all good. Yeah, we can hear you, Emma.
So I haven't been to all of the talks this week, but I have noticed a lot of talk about co-production, which is inherently QI methodology, not QI. And I've also noticed a lot of the clinical audit hero awards went to QI projects, not actually clinical audit. So I was just wondering how, if you thought about how you're going to incorporate co-production into QI, and not at like the HQIP level with the service user network, but actually getting clinical audit teams maybe to actually, when they're doing their action plans, to actually be getting co-production with the action plans to get away from that quality assurance, which earlier this week they were saying they wanted to get away from, and more focused on a QI. Like what have you thought? What are your thoughts on how you're going to try and break down this long-going debate since I've been in QI for about 10 years, and it's still going on about clinical audit and QI? Like how are we going to move past this, because it seems a bit old now. It shouldn't really. I feel like we've got better things to focus on than that, and it's a shame. That's all my sort of thought on it.
It's a difficult one, isn't it? Because I don't know whether Danny, I think you're on the call, and Jill, I think I think in terms of HQIP, it's an incredible organisation and doing really, really good work. And I think the focus that has been on the recommendations coming out, but limited numbers of recommendations, which are written in a smart way, is really helpful. But they are then linked in with quality improvement toolkits, so that we do move away from assurance. But Danny, I think you just had your hand in, so come and rescue me.
I think so. Give Danny a second.
He might have dropped out. Maybe that's what happened.
No, Danny, do you want to come in if you can hear us still? I think he's still on the call. I think you're muted at the moment.
Yes, I'm in now. Thanks, the
There we
microphone. Many have been trying to keep me quiet for a long time. Anyway, I'm in now. Right, I'm at that point, a great point. And virtually all my time at HQIP, there's been this discussion between clinical audit and quality improvement. This is a sterile argument. Quality improvement is a huge, wide-ranging theme, and in the middle of that is clinical audit. Clinical audit is a quality improvement tool. And you're absolutely right. We've had some wonderful quality improvement projects coming through, some of them using National Clinical Audit as their base and others not. And that's exactly where we want to be. We have a resource available to us, which is huge amounts of very, very clean, assured data coming through from National Clinical Audit. And we want that to be used as much as possible by everybody, including quality improvement teams. So the more it's used, the better it is. So we have to leave that argument behind. Many colleagues have made this point. Lots of trusts have put all their kind of personnel, i.e. money, into quality improvement teams. And of course they should, because that's what the front line, but the front line is also generating information through information streams, but also clinical audit streams. And the more we use these information streams, but for us particularly the really assured information, because that's the difference, the really assured information coming through from clinical audit, the better it is for all of us, because then we've got quality improvement based on really assured information. So we have to leave that argument behind. So it was a great point you've brought up. I hope that helps a bit. Thanks.
Thank you, Danny, and thanks, Emma. Really good challenge and good conversation for us to consider. I think we've got a hand up from Sharon. If you're able to unmute. Hi, Sharon.
Hi there. Hi. Yeah, just really interested in the conversation. Stella, thank you. You are a breath of fresh air to the clinical audit community. So thank you. I mean, my background is that I've been in clinical audit since the mid-90s. So I got involved when clinical audit started to become a thing, when it was moving from medical audit across. And at that time, clinical audit was the quality improvement. That is where quality improvement came from. And so there wasn't this confusion. As it developed through clinical governance, clinical effectiveness, and I moved into service redesign for a while, all of that sort of quality improvement stuff happening as just part of business as usual, really, as far as clinical audit work was. I left the health service then for 15 years while I brought up my children and came back 3 years ago to find quite a different but very same problems but very different environment, insofar as quality improvement had obviously then become this big part of healthcare, and clinical audit had been pushed to one side to a certain extent. There seemed to be a big move from local audit work into a lot more national audit, and the clinical audit team seemed to be doing a lot more of the national audits, and the local audits were things done by individuals and not really involving the clinical audit teams, which was quite a surprise to me from a corporate level. My role then changed. I moved into maternity and very much involved in doing audits and supporting the clinical staff, which is what I couldn't do in the more corporate role. And I think my observation and what I really wanted to say was just really that huge change. When I came into maternity, there was a lot of confusion about who should manage me. Should I be under governance or should I be under QI, and where was I sitting? And we made a conscious decision that I should come under QI, the QI lead. And so we have the clinical effectiveness, the clinical audit and QI all in one department. And that seems to be working well. But it's a huge culture change, because that's not how it's been over the last however many years. And so there's a lot of work sort of in moving things on from being, this is audits about data collection, audits about the doctors getting their sign off for their end of term, whatever, or the midwives. So it was part of the student midwives role. Their dissertation had to be a clinical audit project, but it stopped at getting the report. And I queried about the audit with the university and the actions. How would we get them involved? They said they don't need to do that. The dissertation is about getting the report written. So there's been a lot of culture needing to be changed, and we're working on it. We're not there, but just really as much an observation about how things I think have changed over the last 15 years plus.
And Sharon, I think it's not been until I've taken on this role that I've actually recognised that. It's interesting when you're sitting in a provider, so sitting at Croydon, that change has happened around me, but actually I've not really noticed it. And I've noticed it now because people are telling me, but it's not because I've noticed it in my own organisation. So it's really interesting, that holistic umbrella view that you put through. And what also strikes me is, as I've said before, what also strikes me is the audits are, they're standalone. They're often done by a single clinician. They're not multi-professional audits, and therefore they don't get embedded in the service. So we're not getting the return on value, as it were, or return on investment. So I think this is a big conversation, but I'm hoping with NHS Clinical Impact, as well. Okay, there are moves afoot with NHS Clinical Impact, which will be announced after the pre-election period, which I think will start to be able to support the conversations we're having.
And I think that's where I think that's where your clinical audit teams and your clinical audit professionals can support with that, because we know that's what needs to happen, but it's about being able to and being allowed to and able to really make those changes.
Thank you, Sharon.
Thanks, Sharon. We've probably got 5 minutes or so more of questions if anyone else is wanting to, or even comments, if anyone has any other reflections or thoughts that they want to bring to this discussion. There is a whole breadth and depth of conversation going on in the chat, which is really, really lovely to see. Really interesting points. If anyone wants to expand on anything they've said, please feel free to join in. Danny, we'll let you come back in.
Hi, I didn't want to hog this thing, but Stella, I'm going to give you a task. Your task for us, and Claudia will like this one. How do we link data from secondary, primary care, and why do we stop? Why don't we stop using those words? Because everybody, and this has already come up, not just today, but also during the whole week. Patients get ill and go through a whole journey, and we measure little bits of it, and we do that very well. But how do we start thinking about measuring across the whole pathway? And the start for that might be to start trying to link in primary and secondary care data, because that's where we have the data. And Claudia, you can join this conversation as well, because I know you're intimately concerned about this, because the advantages we would get across the National Health Service of having available that kind of data would be phenomenal, and actually wouldn't cost a huge amount of extra money. So that's going to be your task, Stella, for the next few years. How do we link those two things?
And
Thanks.
the ambulance sector as well. I'm just going to add.
Just keep adding.
Claire's going to tell us off otherwise. No, and Danny, you're absolutely right. And I think perhaps as you know, just linking data sets that come into two different systems in the NHS is posing a problem at the minute, and it's causing chaos. But if we truly believe in the federated data platform and the data that's coming in, then actually through the NHS number, and the NHS number is now feeding into the NHS portal, if we can use the NHS number to link up the data sets, then actually that may be possible. And Danny, it might be, I'm not sure this is my job to fix, but I will certainly contribute to this. But it may well be that the metrics that are used as we go forward stop being, let's just go a gynae pathway. A patient's, we stop paying for the GP consultation, then the ultrasound and all the bit that happens in community, and then referral into secondary care, and then an operation and whatever else needs to happen. Perhaps we need to pay for the whole pathway, which means that no patient who has menopausal symptoms or postmenopausal bleeding will go to secondary care, but actually will go to somebody lovely in community who can manage it and actually empathise and do the right thing and actually free up capacity in secondary care to do what secondary care does best. But if you're going to do that, then there's the old conversation that, you know, Alf Collins and Muir Gray used to have, which is payment for the pathway. And if you have payment for the pathway, you then link up payment across, because you would then have to work as a collaborative community. Now, that's blue sky thinking. I know that's madness, but I think that's what we've got to get to stop. Otherwise, there's always competition, because secondary care are concerned about the money that comes into their budgets, primary care and community, and actually it's a single pot of money that actually doesn't belong to us, and it belongs to public purse. And I think, Danny, that's the change that needs to come. Now, we'll have new government, new territory, who knows? But, you know, I think that's got to be one of the recommendations, that we start looking at pathways and symptoms rather than refer someone to gastroenterology.
Thanks.
Yeah, I couldn't agree more with you, Stella. As someone that spends most of their time sitting in the primary care world, I think, you know, joining us up and being more aligned and working together rather than against each other is, you know, a big kind of culture shift that we need to kind of embrace going forward. And let's hope, you know, that progress is starting to be made and continues to be made. I know in some of the other work that you're doing, you know, this is very much at the forefront. So great challenge and great question, Danny. Thank you. I think, just looking at time, I know Gary has got his hand up, so I think this might be the last question or comment for us before we wrap things up. Gary, if you're still there. I think you're still muted at the moment.
Yep, still here. Sorry, limited bandwidth. Stella, so following on from Danny's question and your response, you also mentioned the forthcoming strategy for clinical audits in answer to my initial question. So rather than it being blue skies thinking around having a pathway approach, is there any potential for the strategy moving towards that, or at least sort of some crumbs of hope in the strategy? And also, how do we help you make that a reality and no longer at such altitude?
Okay, so I love how the difficult questions come just at the end. So
sorry about that.
No, I'm teasing you, Gary. Listen, I think there are three different elements to this. So there is a fundamental question, which is, if we consider that we have a single database or a single platform, and that patients and colleagues are wanting our clinical outcome data now, so that we prevent some of the major conversations that have, you know, happened over the last 18 months or so, and that you can spot things early, you can spot clinical deviation early and make change. Then if you're going to do that, you've got to have a single data platform. Now that's okay, but there are processes around it which are really important, which is the data capture, the data cleansing, the ability for IG and making sure that everyone has access to that data, the independent analysis that is curious, clinical and appropriate, and then the dissemination of that, ownership of it and pulling back. So that, in my mind, is all of audits and registries. Now, there are, I can't remember the number. For some reason, I think it's around 600. There are huge numbers of audits. I mean, we talk about NCOPOP, and, you know, I've now been educated to the ones I know about. And then somebody has done an overall trawl of all audits. And honestly, there are hundreds and hundreds of audits. And you talk about the ones on the quality account and then on NCOPOP, there are more outside of that. So the first part is, let's bring stakeholders together and say that if we were, and it's not blue sky thinking, if we were to have a strategy for the next 3 to 5 years of where we want us to be, to add clinical value and do the best for the people that we serve, what is that strategy for audits and registries? That will be ready as first draft by the end of September, and I want it then out to consultation, and I need everyone to contribute. So we have a really honest document that we all then fall behind. So that's number one. Number two is data collection. So we already know that, for example, in ADHD, in some of audiology, the data collection that we have at the minute is not quite right. So we put actions in place to start doing that, but there is more data that we need to now pull together so we can really tell that, you know, even in terms of patient choice, if a patient is referred in and actually, you know, the first appointment with your secondary care practitioner is grand, what's a timeline for the diagnostic afterwards? You know, the data sets need to join up. So that's a conversation that's being worked on, Gary, now. And I think we'll then snowball and get larger and larger. And so that's strategy number two, and that's being developed. There is then a third strategy, which is what do we measure and how do we measure it? And then how do we pay for it? So there are three things happening. They're happening in parallel. Different people have ownership of them. But I mean, for me, definitely in terms of strategy document for us with audits and registries, within a year, we will know, in a year, we will know direction of travel and how everyone is going to contribute to that. And I think that's a 3 to 5 year journey. That's number one. Number two is the measures and metrics. I think we'll be pushed quite hard in delivering those, because they will then inform the third bit, which is how do we measure, you know, this conversation about productivity and adding clinical value. Well, if we're not measuring the right things, then how do we know we've got the right outcomes? So I think, Gary, all those three things are happening. And I think they will come to where we want them to come. But, you know what the NHS is like. Changing something within a hospital is hard. We're talking about wide-scale change. But I think everyone is now saying the same. So I think, Danny, as you say, I think now is the time to really push on these conversations, because they're important. If we want a healthy NHS and we want healthy staff and the right clinical outcomes for patients, then those three strands are really important to what we do.
Yeah. Thank you so much, Stella. This has been such an interesting and fruitful discussion, I think, and there is so much coming out of this, both in the comments and the conversations we've had, and also the chat here. I'm conscious that we are now kind of over time, and I'm sure people have meetings that they need to get to on their Friday afternoon, or if not, are looking forward to wrapping up for the weekend. So I guess this is a natural time to bring things to a close. And I guess just say a number of thank yous. Thank you, of course, to Stella for giving up your time and you know, joining us and having such a, you know, insightful conversation into your thoughts and where things might be moving from a national perspective kind of going forward. And I think many people will be very interested to see what comes out of the strategy you mentioned in the next couple of months. And I hope that our clinical audit community will be very happy to kind of continue these discussions and feedback onto that in due course. And I guess thank you to everyone that has attended on a Friday afternoon, not just this session, but also throughout the whole of Clinical Audit Awareness Week's a great chance for us to kind of come together across the country and share our kind of thoughts and learnings and reflections. So on my behalf, thank you to everyone, and I wish you all a very good rest of your Friday and a weekend. Thank you so much.
Thanks everybody.
Thank you
Thanks,
so much.
Stella.
Thank you.
Thanks, Claudia.
Thank you.
Great.
Have a lovely weekend, everyone.
Cheers. Thanks.